got the good fortune to hear from Joe Rafferty this morning, who's the Chief Exec for the Mersey Trust in the UK. And Joe is going to share his personal account of how he led his service from not such good quality to actually a journey of vast quality improvement, and the targets and process that he used with his team and his services to do that.
Well, thanks very much, Robin, and thank you for extending the invitation to come today. So I'm going to talk about our journey to perfect care, and I'll specifically make reference to our approach to zero suicide for people in our care, but I'll also talk a little bit about another aspect of what we've been doing around perfect care, which is no force first, or zero restraint, zero restricted practices in our services. I thought I'd tell you a bit about Mersey Care. So we're located in the northwest of England. So the city we most relate to is the city of Liverpool. A reasonable sized population in and around Liverpool of about 900,000 people. So we provide for that population everything from sort of social prescribed models of mental health prevention and intervention through to inpatient hospital services. Then across a broader population of about 2 million people, we provide low and medium secure forensic services. And then across a population, 1/3 of the population of England and Wales, we provide a high secure hospital service, so 200 beds of the about 7,800 high secure beds in the English and Welsh NHS. We're the largest provider of learning disability forensic services in the UK. We have a big bed base, 650 odd beds, but that includes the full range of local inpatient beds through to the forensic beds. But actually, 97% of what we do is community orientated. And in the last probably 7 or 8 years, we've reduced our bed base by at least 25% and grown our community capability and so on. We have now, from Wednesday coming, about 8,000 staff as we take on board physical community healthcare services, but about 5,000 staff for our mental health, learning disability and addictions practice. You look over here, are good with the Care Quality Commission, which is a good place to be, obviously. And NHS Improvement, which is another regulator. We have a risk rating of 4, which means that we're a very stable financial and performance organisation. Our population, well, actually we serve the 5 most deprived areas in the country, in and around Liverpool. It's characterised by twice the national average of unemployment, 22% of people in low pay, 32% of children in low income families versus an English average of 20%. Large number of asylum seekers, high dependency on food banks for basic food security. For families, drug death capital of England, alcohol abuse at a really very serious level. As a result, we have the highest level of depression and anxiety in the English NHS, 19.3% versus the English average of 12. And we're upper quartile incidence of psychosis, so 31 per 100,000 versus 24 for the country. So it's a complex population we deal with. So nothing easy, I think, in the task of running our services. So, and we probably, like every other health care service in the world, are facing a sort of a tidal wave of demand. So for the last 5 or 6 years, we've seen a 5% increase in just about everything. Need for beds, referrals, costs, however you choose to measure it. And in a sense, about 5 years ago, we decided that we had to do something radically different to make healthcare from our service both affordable but at the same time of the highest quality possible. So we've spoken now relentlessly about this particular model that we use. So quality without efficiency is unsustainable, yet efficiency without quality is unthinkable. And I show this slide today because I show this slide every time I speak anywhere, even if it's not related to the topic, because it's always related to the topic. This is front and center of everything we do. So improving quality, safely reducing cost, and starting to cope with the increase in demand is our key challenge. So we've begun to think about this shift into providing high quality care. Our hypothesis is cheaper than providing unreliable care. Yeah, and I think we've got some evidence now to show that that's right. But the backdrop of everything we've done is about this. And to do that, we've been very clear in developing a very clear strategy. And the history of developing this wheel is the bit in the middle wasn't there when we first developed it. But you can see that we've got a very simple set of concepts in the organisation. And the power for us of this wheel is it's now in its 5th year of iteration. It's been the same thing by and large, except we've simplified it. There used to be more slices of cake in it. But we've got it reduced down now to probably the minimum number of slices. But right across our trust, you see this everywhere. And from the people who run our supports and facilities services to our most senior clinicians, they can talk about this in a way that the narrative makes sense to them. And that's been very powerful because this is a back reference point at every stage. Then this interesting bit in the middle, striving for perfect care and a just culture, is really one of the things that I think has become our transformation point. So the notion of striving for perfect care. So we started to say, if as a team we delivered all of the slices of the pie, what would it feel like in the organisation? What would it be like? What's the type of service we want to have for our population? That's quite difficult to describe, I suppose, in a way. But we said, well, how about perfect care? How about error-free care? So, and that's been a very interesting pivot point for our organisation. I mean, the easy example is, by the time I get home tomorrow morning sometime, I'll have been on five flights. Well, when those planes take off, I have 100% expectation of safety. I expect to land at the other end. So in our own lives, we've got lots of thresholds that say actually perfect is exactly what we demand. And if the airline industry was not as safe as it currently is and does all the things it does to be really safe, then we'd have a different relationship to that industry, to the one where we can quite comfortably go on board an airplane and expect to get there. Yet we can come to work and in healthcare tolerate a 15 to 20% error rate. And actually I'm not even sure what the error rate is in mental health. And you know, the 15 to 20% comes from studies in other places and so on. And then the bit about just culture. If we're going to strive for perfect care, my team started to say to me, well, that's really interesting. If we're going to have perfect care, how about having a blame-free culture to go with it? To think about perfect care, we thought, well, okay, I can talk about airplanes and ferry rides and things like that, but what would it mean in real practical terms for mental health services? So we have 3 very clear, are you familiar with the term BHAG, Big, Hairy, Audacious Goals? So from the Jim Collins thing, yeah? So 0 suicide for people in our care. Clear enough, you might think. When we say reduced restrictive practice, it's actually an attempt for 0 restricted practice in our service. And that originally emerged as 0 restraint, physical and pharmacological restraint in our service. We've now moved that on to be more generally about restrictive practice. Improved physical health care, so again we moved that into 100% cardiovascular screening for everybody who's in our care. given the risks with cardiovascular disease in this population of patients. And lastly, this is our 4th edition, and the one that really we hadn't foreseen, which is the need to think about a culture of justice in an organisation if you're going to generate a true learning culture. And you need a true learning culture to move from where you are to somewhere that is outrageously different, such as this. So that's the backdrop of what we're trying to do. For reference, an episode of Perfect Care is always safe, timely, effective, equitable, efficient, and person-centred. For those of you who remember, these are the 6 IHI domains of quality. We didn't make them up. But actually, the reason we adopted those is, in my very first board meeting, we spent a long time talking about quality, and actually we were having 6 different conversations. So we didn't actually know what we were talking about. So now, we have an objective that is 65% of the time our board will talk about quality in its board meetings, and we'll identify it by one of these 6 issues. So it's really interesting to be able to talk about money. So when we talk about money now, we're talking about quality, not about money, but about how money drives quality, how investment drives quality. But it's interesting why striving to get these elements right every time reliably feels like, certainly in our system anyway, so controversial. It feels like a really big challenge. And people, get themselves tangled up in all sorts of reasons why you can't do this, rather than thinking about maybe, well, could we? And we've I think, been trying to change the pole and the magnet a little bit from why you can't do it to why you should and how you can think about doing this. So I'm glad that I've picked a quote that's on your wall, just by complete coincidence. But it's been something that we've been really, really strongly passionate about, which is everything I've said up to now is conceptually great, but it only matters if you can turn it into a set of practices. In my view, it only matters if you can turn it into practices. So, for clarity, but our BHAGs are not targets. So we haven't said to the system, if you don't reach 0 suicide, there will be accountability consequences for you. Because that would have directly the opposite effect of what we're trying to achieve. Equally, we haven't really started to break them down into component bits, 10% this year, 20% the next year, and so on. And we've had a very interesting conversation about this morning, because my experience in doing that in other parts of the English NHS has been you end up at some point in time spending years discussing the difference between 49 and 50%. Quite literally. You spend all of your time wasting your time, I'd argue. So we're much more inclined to see where we get to and have a very emergent feel to our strategy, rather than a very deliberate feel to strategy, which is you must be at this point at this time. Of course, if it's going the opposite direction, we want to have some really, really important conversations about what we are doing. But it's a little bit more fluid. The BHAGs are a way of getting to breakthrough thinking. So making us examine the proposition from many and actually increasingly new angles. So I hope that some of the stuff I present today will, what I would say is we wouldn't be doing the work in the way we're doing it if we decided to reduce our suicide rate by 10%. We just wouldn't be doing the things we're doing today. But because we've thought about an absolute approach, it's made us think radically and very differently about how we go about doing things. So as a result, they're not just concepts, they're important concepts that we need to understand and socialize and have people feel comfortable about. And of course, when you say 0 in any of these things, people have a right to say, well, actually, I'm not sure that's achievable. What really do you mean? Is that going to be counterproductive? These are really legitimate conversations to have. So probably 3 years ago, we started to have those conversations. And I don't know, you start with a sort of 80-20, 20% of people, probably resisted strongly. And I think probably today, we've got, certainly on the restrictive practice piece, maybe 10% resisting strongly. But what we have seen is that middle bit, who could either choose to adopt and go with you or resist very strongly, I think have flipped into this is our way of doing stuff now. This is how we go about thinking about this. And that's a very powerful movement to get. But that won't happen just by feeding people concepts. It's about having the determination to drive and develop a set of practices. And that for us has been really important. Moving from concept to practice, it is the bit about credibility, you know. So millions of times I've been in this place, you know, the concept is brilliant, the timeline is brilliant, but actually we're just not entirely sure what we're going to do next. And it's okay, I think, to be in that place, provided you have a mindset, I think, that is about emergent strategy. But we all operate with regulators who just enjoy a good deliberate strategy, you know, because it's easier to service a deliberate strategy in that sense. But it's really important, I think, that we don't rely on the moment then a miracle occurs. So what's different then, I think, about us now is probably three things. First is the concept of foresight. So we have in this sort of zero ambition piece decided to describe the services we want to have for our patients. So we're very clear about that now. The second bit is insight. So listening to understand rather than just to react. And co-production very strongly with our staff, but co-production with service users, carers, people with an interest, just root and branch really. So it's hard to explain, I suppose, the depth that this now goes to, but we have just now employed a leader for lived experience. We have 500 volunteers in the organisation, 65% of whom have lived experience. We have people with lived experience on every single statutory committee in the organisation. The last 4,000 people employed by the organisation have been interviewed by a service user or carer who hasn't just been one of those interesting panels over there. They've been on the interview panel with the same appointment rights and trained to do real deep interviewing techniques. Everything we do has become about this really incredibly strong relationship, both with patients but then with staff as well. So the only two groups we absolutely focus on are those two groups. And the last bit then is oversight. And I think this is actually the hardest bit. So how to begin to operate in leading edge openness, transparency and candour. This is a very big challenge for any health system, never mind one where when things don't always go as you expected, that feeling of inquiry and blame can feel really, really very, very palpable to staff. So these are three features that I'll sort of develop more then during the presentation, particularly, I suppose, with reference to zero suicide, because we've got some new interesting data on that. But I thought that evidence that perfect care is working is also an interesting segue into showing you a little bit about the restraint reduction work that we've been doing. So these figures run principally August 2016 to August 2017, there or thereabouts. But, well, the bottom two are April to March 16-17. Top one is trust restraint figures, then assaults on staff, trust-wide, and then the percentage of assaults resulting in harm to staff. So you see restraints in that period are down 40%. So bearing in mind that we started this 3 years ago, so these have been annual incremental drops, so this is 40% further in this year. But this is across all of our wards, so there are no exceptions now in the trust. This is a 40% reduction this year right across the organisation, and that includes 12 high secure wards with some of the most complex people you can imagine. Interestingly, the assaults on staff are down by 23%. What we see, interestingly, is those wards that really, really are, because under the 40% are some wards that are performing higher than others. Those wards that do this best, we're seeing up to an 80% reduction in long-term sickness of staff. So staff want to come back to work on those wards. You can understand why people are sometimes off sick when you have a very turbulent sort of relationship between staff and patients. During this time period, patient satisfaction has averaged 93% across all of our inpatient settings. So I'd actually like that to be a lot higher, you know, but it's still not a bad indication that what we're saying is patients feel better, staff feel better. Before we started this, the first thing we taught our staff was how to restrain patients. That was the first part of your induction process, was to work out how to, quote marks, safely restrain a patient. So the consequences are very different now for our induction. Our induction is completely service user led, lived experience led, and those guys tell the stories of how restraint re-traumatizes. Restraint doesn't keep them safe. Restraint re-traumatizes them. And as a consequence, we don't train people in the same way in restraint reduction. So that's a fundamental shift in our behavior around this whole set of practices. And of course, there's one of the things is the driver diagrams that sit behind this. So for the quality improvement, people who love these things, they're there. But the factors that contributed, as we found out over 3 years, is inconsistent ward rules or staff requirements. So unreliability built into the service at every stage. That's not hard to fix. An unpredictable, unsafe or boring environment. You'll recognize some of that from some of the head nods. But we cannot, you know, simply expect not to change things, but the product of what we do to change. It's just logically incoherent, that. Being asked to do something you don't want to do, or being asked to stop doing something you do want to do. So moving from the concept of institutionalization and one size fits all into real choices for people, real choices of meaningful activity for people who've been treated disrespectfully in front of peers. And of course, the triggering of previous trauma. And I think this is now well recognized as a set of issues. But for us, these have been things that we've focused on almost religiously to remove from our service. And the thing that we have put in is compassion. I think I can honestly say that we talk about compassion as a real thing. And the 6 key areas that we spend a lot of time talking about are here. I don't think you'd probably disagree with any of them, and I'm sure you could maybe add to some of them. And in our own NHS constitution, we must respond with humanity and kindness to each person's pain, distress, anxiety or need. And I'm pleased now in the English NHS, we've stopped thinking that that only applies to people with physical healthcare needs. And it now is increasingly a dialogue for people with behavioural needs as well. We have our guide to reduce restrictive practice. We set this, of course, through that strategy wheel as an organisational priority. So there's nobody in the organisation doesn't understand what we're trying to do. And each annual operational plan will show how this is going to, at a ward level or team level, move onwards. So it becomes an embedded way of doing things. And critically, this bit is simply the big thing that changes the sense of direction. So when I first started in the Trust, I'd never worked in mental health until 5 years ago. And I heard about restrictive practice and restraint in particular, and I thought, well, I suppose it's a sort of, you know, you put it in the necessary evil thing, keeping people safe from themselves and so on. And then a very powerful presentation from a service user who had been physically, sexually, psychologically abused from being a baby till her late teens, said, in a presentation to her staff, said, when she's restrained, the hands that go over hers, she sees adult hands covering her 6-year-old hands, you know? So when she was about to be physically abused. And actually, when you hear that, you can't decide any longer that this is acceptable. It is simply not acceptable. That's a different thing from knowing how to make it not acceptable. But the first step was to have people like that tell their story to people like me and you guys who've been trained in the system that says, well, actually, it's a necessary evil. It's one of those things you have to protect people from themselves. Well, it's curious. Sometimes maybe we have to protect people from our institutionalized beliefs in a way. But I think that powerful testimony of Iris Benson has resonated through our organisation, and we dig out those stories and we get those people with their permission to talk relentlessly about them, and that makes a massive difference to our ability to transact change. Lots of stuff inside the restraint stuff that I think might be interesting for you guys, but I think you've probably done a lot of this anyway, but it's great to see that lots of things are happening in common, but everything from values-based recruitment, trauma-informed care through to co-production drives our no force first philosophy. Our ward approach is very much about great practice, but lots of compassion in what we're trying to do. Ward-based approaches and lots of evidence-based tools, probably many of which you're very, very familiar with. We have also applied this in the most extreme end, most complex end of our service, which is in that very small proportion of patients in high secure services who have been in segregation for a very long time. So some people 7, 8 or 10 years in segregation. And we've thought about a model that we call it the HOPES model, harnessing the system, engage the person, opportunities for positive structured activity, preventative and protective factors, and enhancing the individuals and the staff's coping skills. All of that inside the system in that sense. Thinking about the foresight bit, creating the future we want to have through perfect care. For zero suicide, we started this in 2015, really as a socialisation piece, and in the last 2 years I've been working very hard on the concept into practice piece. So the elimination of suicide of people in our care, not of everybody in the population we serve, but of people in our care, because we believe suicide in our care is avoidable. There are evidence-based interventions that are very well known, and we can maximise their delivery. So therefore, these people, we know them, and they're amenable to the avoidance approach, which is very different to somebody who we don't know in healthcare services who decides to step in front of a bus today. It's therefore both a concept and a clear set of practices, and in our view, it is the ultimate expression of commitment to patient safety and mental health services. So when a relative finds their very distressed loved one in the care of a mental health service, what those relatives have told us is they breathed a sigh of relief. They thought it's going to get better from here. And what happened? It got so much worse. It got unimaginably worse for these folks. So I think if we're going to be serious about this, and if we're going to be serious about safety and mental health, we cannot, particularly I think deaths in an inpatient setting, we cannot tolerate that as anything other than a never event in my view. And I hope the English NHS moves that way soon. Deaths in the community in our care are very much more complicated, and we need to think a bit differently about those. But for us, it's maximum expression of patient safety. And we've had to tackle this with focus in 2 ways. Better processes, so better organisational performance, so knowing where you are and all of those sorts of things at any one point in time. But just as important, maybe more important, better culture, so better organisational health, not just organisational performance. If you're familiar with McKinsey, everybody's familiar with McKinsey. They're very big on the organisational health bit, and they've done some fantastic work on it, and that's worth a look. But these 2 things have been hugely our focus. And we now, as a result of that, I suppose, work across 5 domains. The bit in the middle is interesting, our practices. So what changes in practice do we need to achieve a desired outcome? I think there's a tendency to work there, or you could even spend all of your time working there. And I think it's one of the risks, I suppose, for a quality improvement movement, is naturally you want to change stuff. And this is the most amenable, lowest risk, lowest entry point place to change things. So of course you've got to do it. I mean, you've got to. But we've been sort of clear now over time, and our story is that you need to do the 5 things. So you need to think about what you're looking to achieve. We had a great conversation this morning about the metaphor of a journey, this being a journey. But a journey without a destination is a really interesting idea, you know. It's great if it doesn't matter, but this stuff matters, so you have to have a destination for the journey to be a part of. And we've been very clear in terms of outcomes, and we've adopted an approach that says 0. It's controversial, it's difficult, but equally it's relatively easy to understand. In the context of suicide, if the number isn't 0, would anybody like to say what the number should be? 5, 10, 15? Do you want to have the conversations with those families? Because I don't anymore, really don't. So in a way, it's a provocative and clear to understand. It's not clear to do, but it's clear to understand. Accountability. So what do we need to adhere to? The core practices that reduce cost and improve outcomes. And how do we feel accountability without feeling blame? It's a very complex dynamic, that one. On the other side, capability. So do we have the capability to get these desired practices? Even if we had the people, which I think having conversations this morning here, like in England, even having the people is a challenge, never mind having the capabilities in those people. But what does that mean for us in terms of our forward planning for a system that feels like it's going to have these sort of outcomes? And then lastly, mindsets. What changes in mindset do we need to make? And I'll show a bit of data in a minute about what I mean around mindsets. But for us, these 5 things feel like, I'm not sure what proportion they need to be in. You know, we haven't done it long enough to know that. But I do know that you can't spend your time exclusively in one of these domains. I think you need to have some element of all of this in the recipe. And I think this reflects a little bit, and we use this quality balance all the time. The temptation in talking about all of this stuff is that it's all about added value and innovation and brilliant stuff like that. Actually, we insist our organisation spends most of its time in the blue bit of this triangle. Do what you know really works and works well. Do it reproducibly and do it very well. Go up to the next bit, which is a brilliant place, I think, for the practice bit of the 5 domains, and get rid of all of the nonsense that's duplicated and gets in the way and so on and so forth. And then spend the right proportion of your time in the innovation space. So I think it's, again, this is something we do all 3 of, and we probably do them something in proportion to the sizes of those particular boxes. So don't think this is all about really interesting new stuff. It's as much about landing this stuff we know that works really well, but really reproducibly. Improving pathways and process precision, therefore, which is about getting the basics right. You'll see this is a sort of PDSA cycle, and I'm teaching you how to suck eggs if we're talking PDSA here, right? Yeah, so everybody knows that, and that's great. And we have driven a huge amount out of these PDSA type cycles. Tremendously important in terms of what we now know about our suicide prevention practice. But I suppose what I'd also say is they're necessary, but I argue they're not sufficient, because they'll drive you into the practices box all the time. Yeah? And we do that loads, don't get me wrong, we do it loads. 1,000 people receiving quality improvement training, 100 improvement projects at any one time in our organisation ongoing, a big drive around leadership and team development and all of those types of things, which I think pays dividends. I'll show you later it does. But actually, you know, if I have a message, it's expand into the other 4 boxes as well, and start to make sure that you support your practice change with the organisational health pieces that go with this. So for us then, around our zero suicide approach, we've developed 4 cornerstones that are really very simple and probably not very controversial. They are service user and partner engagement, safe and effective care and treatment, a competent workforce, and research and evaluate. So know what happened and why it happened. And then we've got 10 very simple practices. So these are not really debatable, I don't think, at one level. You might add some things. But what we're really trying to get at here is the 10 practices, because it's the bit about knowing what you're going to do around all of this stuff that will matter to patients. And certainly my view is for our staff on the front line, it matters that you're helping them change things, but not just willy-nilly or because there's a joy to change. Don't know if you experience it, but we have had lots of quality improvement projects that we're moving on to the next phase, which was, about let's look at the last 2% of something, and we wanted to do them because there were real advocates and people liked doing it and it was very interesting. But did it shift any of the big needles for us? I don't think so. So it's a careful balance between not taking away from that, because that engages people, but at the same time we have to be in the mission of changing the big needles for the organisation, and that's what we think these 10 practices are about. And there's a lot of stuff in there that I think is again, it's not rocket science, quite honestly. But I'll talk about various bits of this as we go in terms of some results. Driver diagram again, just to make sure that it's there. We started with a simple thing, making accountability clear. So we were the first, and I think actually the only NHS organisation in the NHS that has a zero suicide policy. So we decided that we needed to be very explicit to staff. Although the policy is a bit like the contract. If you get to the contract and you're arguing over the contract, you've had it. There's something wrong in your relationships. So I suppose we feel like that about the policy, but it was nonetheless interesting and useful to have it. You can find it at a web address, and if you've got feedback, we'd love it. We thought a lot then about learning. It's one of the key practices, and we've got a very clear learning strategy, a level 3 strategy that is very, very focused on senior clinical leaders in the organisation, real decision makers. A second level that is about practitioners, and a suicide awareness level, a level 1, which I'm going to talk about now, which was, curiously, we discovered that we didn't have a mechanism in the organisation to make everybody suicide aware. That meant everybody in the organisation. So it seemed an odd one to suddenly declare yourself as a zero suicide organisation, and we had no organised way of making sure that everybody, no matter who they were, was suicide aware. And we had a really interesting sort of exploration around this. We discovered no agreed competency-based approach to suicide prevention, either for gatekeepers or practitioners in the UK. So we set about developing one for ourselves. The evidence base actually for training as an intervention is equivocal at best. I mean, certainly it increases people's knowledge, but does it really change their practice? Does it really change their cultural perception of what goes on in a service that they run? So we started to build our own evidence base. And then this is a really interesting one. Training materials available are both time-consuming and costly. So let's say we had 5,000 people in the organisation at the time. We worked out if we were going to train everybody in awareness to the same level, it would cost us somewhere in the region of £5 million by the time you buy the training materials, you take people out of work, you do the backfill, you do all of those things. Now, in another world, a chief executive would say, well, £5 million on training, let's call that a pressure for next year. That's the sort of language we use, isn't it? It's a pressure for next year, which is shorthand for saying we're never going to do it. So the difference, I think, in committing to zero has been, one of the things we did was set up a Safe from Suicide team. Sounds very grand. There's actually only one full-time person in the Safe from Suicide team, but it allowed lots of people to be co-opted in around one person with real knowledge. And that team will go out to teams on call and advise around really complex people and their suicide risk and so on. And where it's got to now, of course, is that people really trust that team, and we've had a number of people now ring the team up and report their own practice, self-report their own practice to the Safe from Suicide team. So they've said, actually, I don't think I'm competent enough in some of the skill sets and competencies around suicide prevention. Can you do something about this with me? Now, I don't know who they are, and I don't want to know who they are. But it's brilliant that people are self-reporting into this team now. That, for me, is the mark of a very, very mature system. Secondly, with the Safe from Suicide team, they felt really strongly that everybody should have a suicide awareness level. So they said, well, actually, if we can't afford it, we're going to have to invent something that's different. So they got off and they did invent something that's different. And I don't think we'd have done this if we'd have said, let's get a 10% reduction in the suicide rate. We'd have passed it off somehow. But because we'd committed ourselves to a very different paradigm, we were clearly in the place where we needed to do something different. So this training's mandatory for everybody who works in our organisation. Since April, we've got to 80% compliance, which is huge actually, considering that compliance for other things, fire training and things like that, is probably less. So it's an indication that people want to do this stuff. It's an e-learning package, takes about 45 minutes, can be done individually or as part of a group. We've now got a new mobile device, so it can be done now rather than a clunky way on our computer system. It can be done from your mobile phone. And it takes about 15 minutes, and an initial positive evaluation that it changes attitude. From about £1,000 a person, it costs about £3.50 to do. So, it's hugely, hugely affordable. It looks like this. It's very much about talking about suicide. It is an awareness level, this. So it's not a clinical level, that's levels 2 and 3. To raise awareness, get people talking, preventable and avoidable. Suicide impacts us all, and suicide's a very personal thing. It talks a bit about the situation, facts, figures, personal stories, but critically engages at an emotional level what it means to lose, and then presents scenarios and coaching, which is a really interesting way to do this. So you go down through these 3 different relationships, and you can turn left or right at various stages, and you can work out what you might have done better. You can go back into a coaching cycle and discover what you might have improved and so on. So it's very much designed for millennials, I have to say, many of whom are in this room, I'm sure. But it's very much designed for people who use and think differently, because that's a very important population to get at here. See, say, signpost. The interesting thing, we ask some questions before and after. And there are many questions, but the 2 that I think matter to me anyway are, is suicide a selfish act? And is suicide inevitable? So the left-hand purple bars are the before and after for the professional groups. So a 20% to about a 7% reduction in selfish act. The reddish bars are corporate staff, non-clinical staff. So a very, very big drop in the selfish act question. The inevitability bit, I find the professional one really interesting. So 55% of professionals considered it inevitable. I think that's really interesting. But the drop is very significant nonetheless. And then a big drop in the inevitability question. So I think for £3.50 and now a maximum of 15 minutes investment, that's a really pretty dramatic change. It's the sort of change we're looking to see really around. If you remember the 5 bits to the very left-hand side, the mindset bit, so that feels to me like this is really getting to the place we want it to be. Level 2 training is very much more complicated and drives into the change of pathways. So formulation of a formulated approach to risk, identifying risks differently, identifying prevention steps and so on. The use of resilience, working with families, all of those things, and is heavily based around safety planning. Safety planning has been very, very important for us. Where we do safety planning really well, and it is a bit of a roller coaster, if you look at safety plans over time, some of them are great, really great, some of them are still lousy, and that's classic practice change then to raise the level of that. But where they're really good, we see 0% readmission to inpatient wards who fully implement the plan, and a reduction of about 50% in reattendance post-discharge to the emergency department. And that's across a period of 2016 to date. So that feels like we're really starting to get a grip now with the safety plan piece. What we don't have is reliability in the safety planning, but where it's done really well it has a real impact on the sort of leading edge markers. You know, we've got to make sure, of course, that these people don't in the end complete suicide. But if you think about a leading edge marker, this is a good one. Team safety plans right across the organisation. We're trying to get team safety plans in place. This is the one from our communications department, a non-clinical department, a corporate department, but one that often receives phone calls from distressed people because communications is often up on the website. So not unusual. So they have their own safety plan now. So in communications, if someone rings who's suicidal, everybody has a red flag. You can put a red flag up. All the other work stops. It's not important enough to be more important than this. And then we get help around. So rather than doing what we used to do, which was, well, hang on, I'll put you through to the crisis team or your ward or whatever, and then you click and the phone rings forever and nobody answers it, we make sure that we never lose a call. So we never lose the call. Now we keep a patient on until somebody can get to help them. We wouldn't have done this if we'd said 10%. You have to do something different in order to do really different things, I think. So the problem of measurement, this is really interesting. So lag in data. So when is a suicide is so late that it's like driving down the highway but only having your rear view mirror to look in. So it's a complicated thing to know where you are at any one point in time. So we need to develop comprehensive dashboards to present our best position. We need to think about establishing leading edge indicator sets. And for me, the most exciting thing is to think about new predictive analytic tools that take us to a different place. Not what was yesterday like or what was the day before like, but what's tomorrow going to be like. That for me feels like it's 21st century suicide prevention. Progressive reduction in our trust suicide rate. We started here. It may not look very dramatic, but it's a distinct reduction in the suicide rate. So per 10,000 caseload, we're seeing a reduction in our suicide rate. So that in itself feels reasonably significant. Probably these figures up to about here are reasonably reliable. We've got to do these ones. But you see my point, you're always looking backwards to know if you've been successful or not. So we're starting to think about getting the basics right. So this is our zero suicide dashboard. I'd say we're one of the most advanced trusts in England around the whole question of suicide prevention and reduction. And you'd think, wouldn't you, that if it's really important, as all health systems suicide prevention plans tend to be, you know, we make a big deal about them, you'd think we could, at the press of a button, bring up all the data that's relevant around prevention. It's taken us a year to get to this place. So we've now got it, thankfully, you know, and we're in a position where we can start to look at lots of key metrics and examine it right down from the overall trust view down to an individual ward or team at any point in time. But, you know, it's taken a year to do this. Either this stuff's important or it isn't important. You know, can you imagine having an emergency department target that you can't measure the parameters around it at the touch of a button? Or, you know, key infections in intensive care that you can't pick up just at the touch of a button? Yet it seems to be okay that we can talk about reduction of suicide, but not actually get in the business of being able to manage and understand the key indicators around it. So, penultimate to the top of the pyramid is self-harm presenting to clinical services. And we know that people presenting to clinical services, particularly the ED departments with self-harm, run a very significant risk of moving to completing suicide. It's a very strong indicator. So we've started to look using Innovance Pulse and other things at some of that data and have pushed together a clinical outcomes and routine evaluation, a core review, for something that we call hope therapy. So I don't know what happens here, but in England, lots of people who end up in an ED department get registered there, but there's very little done, you know? So we've started to do brief intervention there and then, or as close to there and then as possible. So a reduction of 5 points in the core score is a statistically significant difference. And we're seeing now, in terms of clinical outcome by the patient group here, we're seeing a reduction of 5.35. So better outcomes being generated for patients by doing brief intervention at the time. the number of days between referral to first appointment is about 14.71 days, which feels like about 14 days too long in reality. But actually, this was as long as a piece of string previously. So it tells us that that time's coming in, you know. Interestingly, it's consistent with cancer care in the UK, 14 days to a 2-week urgent referral. But I think our intention is to collapse this gap even further by continuing with the intensity of the brief intervention piece. Finding signals in the noise using this type of technology. It's been really interesting for us. Complex self-harming behaviour. For 5 years of historic data, we've seen a rise in self-harm incidents, and these are very complex. They're principally ligature events, but not using ligature points. I don't know if you've seen this as a development. So people using it's really very serious self-harm. But the argument would be not intended to be suicidal behaviour. So not using ligature points. And it's complicated, I have to say, and I don't think we'd have seen it in all of the things you can look at, except this relationship has been drawn out using Innovance Pulse. So it's a mechanism to draw out things that you might otherwise just miss in data sets. So it gives us then knowledge of method, date, time and location, which is straightforward enough. But we're now starting to push this towards staffing, the levels of staffing and the skills of our staff, medication, mood, what the weather was like. Is there anything else we want to put in there? So we wouldn't probably normally have the capability or capacity in our service to think about these additional issues. But for Innovance Pulse, you know, it's nothing to add these additional issues in as long as you've collected them. And over time, well, I hope that we're going to be in a position where on some of our wards we'll be able to look at particular patients, look at their risk profile, look at where, when, how and what the conditions might be that would maybe trigger that person's suicidal ideation into an attempt to complete. And that's the reason, that's one of the great strengths of artificial intelligence, is to be able to provide this power into something that feels like, you know, we probably all harbour some views that these things are important, but we don't know or haven't got the bandwidth to go about doing it. So, of course, acting on this, so this is 2016 to December 17 in the self-harm project. So taking the stuff out of Innovance Pulse, we've been looking then at reduction in this self-harming behaviour, which is now reduced to by 43% on the wards that we've targeted most. And then we roll this out as we go ahead. So part of the pattern of how we do things is very familiar to you, I'm sure, will be we avoid pilots and like to think about prototypes. Seems like a slightly stronger mechanism model. So we push down the prototype sort of model. But you can see again, every time, again, another very significant reduction here. And this is a reduction on something that we didn't, I think, know anything enough about without starting to think about how we get towards that predictive context. Another bit of prediction. People in crisis are at risk. So can we use algorithms to predict crisis as well as a clinician can predict crisis? So we've gone through a historic data set, used some algorithms now to say these patients are at a high risk of crisis, and there's a very strong concordance between that and what the clinical teams described. So an opportunity here to say that the computer can help take some of the work out of it for clinicians and get you your top set of people. But what's really interesting about this is, can we get this algorithm to predict medium and lower risk? Because that's where we see a lot of the deaths actually for suicide. But can we get to that 2 weeks before the clinical team's going to get to it, because the indicator sets are there? And it's making us think about stuff that we all know. So debt, relationship breakup, sofa surfing, as well as a history of suicide, a history of crisis, recent crisis, all the things that you expect are in there, biopsychosocial components. But can we fine tune that enough so that we can actually get to people before the breaking point? Because this is a bit after the train has crashed. We want to get away from that and stop calling it crisis service, you know. But it's a good indication that you can get into this world really quickly. Insight. What we want through co-production. So design thinking is the way we do this, and I love this. So design does this, and the user experience does that. I mean, and we've all done it, so it's sort of perfect in that sense. But design thinking is a human-centered innovation process. The reason it's important is it takes a concept and actually makes a set of practices out of it. So design thinking is well described in the design industry. We just haven't used it much in healthcare, but it's a very almost like a protocolized way to begin to think about doing this, to capture and so on. It's why we've gone with it, the concept into practices. And this is what it's about for us. We're brilliant in health services, certainly in England anyway, doing the precision bit. But actually what the patient wants to know is, look out. So it's about significance, really, this, rather than us designing something that's beautiful and perfectly precise, but generally wrong, you know? The old phrase, generally right, not precisely wrong. So this is what we're trying to get at. And it focuses on sort of, is it viable for us to do a business space? Is it feasible in a technology space? But this critical bit, the human space, is it desirable? Is what we're trying to do desirable? And we've made the changes that we're trying to make, at least around suicide and restraint, because it's desirable from a patient and user and carer perspective. That's a very strong drive. And experience, the bit that sits in the middle, is a very significant innovation space for us. And the innovation, top of that green triangle, isn't complicated. So I'll go to this first. So one of the innovations that we've undertaken is the development of something called the life rooms. We call it real life support. And this is a movement away from outpatient appointments. So we see people every 6 months, whether they need to be seen or not, and whether they want to be seen or not. I don't know if your system's like that, but ours is. So we send a letter to somebody who's feeling perfectly well, or we'll send a letter to somebody who can't get out of bed with depression, but we expect them to come and see us, as suits us. And then when they don't come and see us, we call them do not attends. I mean, it's ludicrous. It's ludicrous. So the life rooms are about moving away from parent-child relationships to adult-to-adult relationships. It's based on the notion of a college. Our recovery college is a big thing here, does that? Yeah? So it's based on the concept of a recovery college. But in England, they've become a bit sort of stale, I think, recovery colleges. They're still very much in services. Our life rooms aren't in services. We've got one in Malton, which is at Carnegie Library. It's a beautiful thing. You feel special when you walk into it. There's no slippy blue seats, you know, the sort we have in public services in case people wee on them. It's high quality furniture. It feels good to come in there. It still hosts a library to keep the community intact there. And it's a public space, so you don't know who's in mental health services and who's just in using the library. So it classically destigmatizes what we're trying to do. And we run out of this 30 or 40, I think, different courses now that range from management of anxiety, depression, self-confidence. And we run those courses in ways that are very responsive to what people want. So one of the confidence courses is actually run as a stand-up comedy course. And we've got a couple of people now who've gone on to, they're making a living doing stand-up comedy, but they entered our service with a real lack of confidence. So it's a really bizarre thing. But it's doing these things in ways that feel like they're adult. It feels like real choices for people, rather than actually in an outpatient scenario, it's very little choice, I have to say. So we opened the Malton Life Rooms about a year and a bit ago. We've had 25,000 people through there. We think it's about 25% cheaper than an outpatient's appointment, so it saves money. And the evaluation from people using it is just stellar. 50 voluntary sector organisations operate out of there with us, and about 40 general practitioners refer in there. So everything from those confidence anxiety courses to learning how to cook cheaply but healthily for £5. So we have a big relationship with the local supermarkets where you can get a slow cooker and a pack of food for £10. It's all the sort of stuff that just starts to move people to something beyond diagnosis and illness, into life beyond, so self-care, management, all of those sorts of things. So this for us is a massive piece of co-production, which as we do this more and more and more, I think will become part of how we radically change our attitude to mental illness, which will change our attitude to restraint, our attitude to suicide, our attitude to physical health. It'll be no longer tolerable, I hope, for these things to be as they are. And it will work like this as predictive analytics. Patients downloads it and configures the app, and you get an initial risk score. Appearance of a mildly negative comment on Facebook or social media. So we've got permission from the patients and from social media organisations to look at social media using this. So a movement away from that narrow slot of when they come to see us to the rest of their life. I think this is at the root of prevention in my view. That changes potentially risk again. Patients are asked to journal. Relatives can journal as well, so we can look at the journaling experience, maybe changes. A low mood score in a mood meter might change it again. The point is, when it triggers a particular point, maybe by somebody going to hotspots for suicide, that becomes like a blue light call. So services go to the person using GPS. And that's a very different way to think about patients going through a suicidal experience or suicide thinking experience than what we currently do. And it moves us away from that notion that, you know, I still don't get it that somebody can be ready to take their life. And it's a bit like having central chest pain and saying, well, we'll get an ambulance to you sometime in the next fortnight. You know, it would just be outrageous, absolutely outrageous. So we need to think about mechanisms that do this a bit differently. Concept or practice? Well, it's actually practice. So, yeah, this goes into, we're recruiting for our clinical trial in this now. So this is a piece that's very real. So the app, the tool exists, the framework exists, the ethics agreement exists to do this. So maybe the next time we talk, we'll show some data out of this. Lastly, oversight. The future we want through transparency. So it's an iceberg. I mean, I'm sure you're really familiar with the iceberg bit. There's an absolute tendency to look at the bit above the water because you can see it. The bit that sinks the boat is the bit below the water. And that's the stuff I think that's really hard. Beliefs, perceptions, norms, traditions, shared assumptions, the whispered stories, how you really feel, the way we really get things done here versus the way we say we get things done here. This for us has been by far the hardest, and for me was the least predictable bit of all of this. Maybe that says something about me, but this has been really important for us to tackle. Systems designed to give the result it does, the IHI thing. We in our system have outsourced claims management to a government body. I think you do that here as well. Interestingly, it leads to an us and them scenario. Very defensive sort of approaches from litigation authority, I would say. Average 8 years from incident to close for a compensation claim. Can you imagine being a bereaved relative and having to go through 8 years to feel that you've got a resolution to your loss? I think that's inhuman. And the language about this, which is investigate, hearings, tribunals, all of these things, just implies retrospective blame. If you've been on the other side of one of these, you really know what it means. We're going to investigate you. Oh, really? You know, what did I do? But that's what it says. So, full consequences of incidents not felt by trust management or care teams, because some of this is very remote. And then, think about operationalising transparency and candour. We've got 4 domains. Incident reporting. So we're a very high incident reporter, but low on harm. So that's the way we want to be. That's absolutely the way we want to be. We're happy with that, but we want to report more, but report more near misses. Risk identification, need to be much better at that. 72-hour root cause analysis, reviews. I'm not sure root cause analysis works for suicide investigations. I don't know if you use that here or not, but it feels like it's right in some industries, but not in ours. So we're thinking about what we can do here that's more relational rather than process-driven. And this critical bit about early resolution for people who are bereaved. But the idea is that you cannot get into any of these things without a just culture. And the just culture permits learning. And it, you know, the more I've looked at this, the more that this is absolutely true, I have to say. In terms of early candour and early resolution, so bereaved people are involved rapidly in our organisation, so they can see me or the medical director within 24 hours. I mean, that rarely happens, I have to say, but you know, people have seen us. Reports are shared well ahead of the coronial process. This is really important. We see people previously showing up in the coroner's court, bereaved people who, for the first time, hear what goes on in the report, which just isn't right. So, well up front now is our intention and what we do. Early resolution for compensation. So, as a result, we've got very low litigation exposure, so that saves us a lot of pounds. And if you won't read the letter from here, but where the trust has failed someone, we're very explicit. I want to confirm that I unreservedly apologise for the failings that led to untimely and devastating death. We're very clear about it as an upfront apology. And it says, we wish to settle this out of court with you, not because we're looking to be cheap, but because we don't want you to spend 8 years, you know, and we can employ all the lawyers, and you can't. It's not fair. It's oppositional, and it re-traumatises people. So that approach has started to really, really work for us. And the interesting bit about the just culture is if you're able to do that more and more and more, the money we spend on the lawyers, we can spend on service improvement. We can put it back into the things that people value rather than the stuff that nobody values, except the lawyers, I suppose. So very real for us. So barriers to transparency, why isn't this easy? So we spent a year before last talking to 400 senior clinicians in depth in a very confidential way. So nobody's identified. But 50% of them said the biggest barrier to transparency is fear, blame, shame, consequence of dismissal. That's horrifying, truly horrifying. And I don't think I run an organisation that has those characteristics. I don't think my board are people who want that to be the way senior clinicians feel. But if that's the case, and I think this is the case in pretty much every healthcare organisation I've ever encountered, so we might be talking about perception rather than reality, but it doesn't really matter. Perception is reality in many respects around these things. So if that's the case, what happens then when we get to the investigation bit and the evidence gathering and all of these sorts of things is people clam up. People stop remembering it the way it really was. They're not lying, they're just not remembering it the way it really was. People go off ill for months at an end. So it takes us 6, 8, 9, 12 months to conclude our piece of work on this. So 12 months later we start to talk about it, and guess what? It doesn't quite feel the same anymore. The urgency's gone. It was then, it's not now. So can we bring a sense of urgency into this with absolute realism where people feel free to talk? So one of the things we've been experimenting now with is safe spaces. So where we've had some deaths, none of the suits show up. So the instinct is, for me, of course, to get out there and get on the ground and see what's going on, or my team, or the medical director and loads of other people. And we think that's great accountability on our behalf, because we're there, we're supporting. Our staff think who's going to be suspended. That's actually what they're thinking. Yeah. They're thinking, here come the suits. Who's going to get suspended today? That's horrific to consider that. So we don't do that now. I do go, but I go weeks or months later. So we have safe spaces where the team come out. We have people who really understand and know risk, but they go and they talk really openly, confidentially, about the stuff that really matters. And that's now driving learning cycles for us in a way that we've never really experienced them before. So delivering our ambition of perfect care depends on a non-punitive culture, which is really about saying when something happens that we didn't anticipate, compassion should be our first response. It should be compassion, coaching, retraining. In hardly any circumstances I can think of should we be really pushing accountability really, really hard. I mean, there are obvious cases, but the point is where you draw the line is really important for a just culture. So we had one experience of a non-clinical person who had pulled a patient by the hair across the floor, and everybody sat up in horror. And everybody said, actually, that's a clear-cut case of full accountability. And somebody else said, but what if the patient hit me? Isn't it a fair thing to do to fight back? Thankfully, that person was not a clinician, you know? But where you draw the line can be subjective, and people will draw the line in different places. That's why you've got to have a mechanism around this to ensure that it feels like it's truly just. It's not straightforward, but it's important. So responsibility and professional accountability drives our organisational learning. It's not about blame-free. Blame-free is as bad as blaming. Blame-free means you can do anything. It's that axis between accountability and learning. Critically, the last two bits, a prospective outlook rather than a retrospective bias. What does a retrospective bias mean? The temptation is to say, oh, well, just tell me, who was the ward manager that day? You know? How many people, who was on? You know? Instead now, we ask what and how, not who. So, hardly anybody comes to work to do a bad job. Systems and processes help people do a bad job. Not very few people actually come to work to do a bad job. And we've got stellar examples of this. I'll skip this one, but this is the critical bit really for us, the just and learning culture. Staff said to us, you know, great idea, I love it, but it might be chief executive hyperbole. I think that was a very polite way of describing something else. He said if this is going to be real, the number of disciplinary cases in the organisation and suspension cases in the organisation should be different. Yeah? So you can see last year with this year. So it's a dramatic change. Largely by us starting to say as a team, stop using policies to drive everything. The policies are there for, you know, in the last event that we can't agree something. People say, what important tools and techniques have you used to do this? We use something that's a very old-fashioned thing that people have forgotten about. It's called common sense. Yeah? Use your common sense. Start to work it out. Have relational behaviours in place instead of transactional ones around policies. So that's a massive change for us. Interestingly, it's associated with about £500,000 a year saving as well, because there's a lot less nonsense and paperwork that goes on. So again, saving money while we're dramatically changing the feel of the place. Now, I don't know whether this is going to turn us truly towards a learning culture, but what I can pretty much say is if we'd stayed here, we wouldn't have penetrated that learning culture. Interesting experiment is, will here get us into that learning culture? I think we stand a better chance. So a can-do mindset is more important than resource. So I'd say resourcefulness is more important than resource, at least in the short term. I mean, we all like a bit more resource, and it would make it much easier, but you can do stuff. So we've put very, very little extra resource into this. Our commissioners haven't given us an additional penny to do this. We've recirculated our money allocatively. We've allocated it more efficiently, I suppose I would argue. It's about collective intelligence, not individual genius. Really, really important. And it's about empathy and not ego. That has been a fantastic lesson for a chief executive, I have to say. We've got 4 values, and respect is one of them. But I think respect has become a prevailing value. It's very difficult in the just culture piece to not have respect as a huge prevailing issue, both peer-to-peer and staff-to-patient. And then the last bit, the old adage, culture eats strategy for breakfast. Actually, it eats your operational excellence for lunch and just about everything else then in the process. You've got to work out a way to deal with the strategy, or to deal with the culture. So, I hope that's been sort of useful. It might be longer than you anticipated, but... Fantastic. Okay, thank you. So really important, I think, in thinking about your change programme, to have, I would say, 3 really key principles behind it. Know what you're trying to achieve. So think about foresight and the importance of, as an organisation, having sufficient foresight to be able to say, this is the type of organisation and the type of service we want to run. Secondly, really important to draw the people who are your customers absolutely to the heart of what you want to do and achieve. So use insight as a big driver for innovation. And lastly, and maybe the most difficult thing here, is to think about oversight. So the power of transparency. In our system, we've started to talk about the need to have a just culture if we're going to truly learn. And we all get things wrong. Every organisation gets some things happen that it didn't anticipate. But operating in a transparent way that says this isn't about apportioning individual blame, it's about thinking about the system that we operate in and beginning to look at the weaknesses in those systems that give people permission to stray from absolutely doing what is the right thing every time. So I think if you look at those three dimensions and then build through with the concept of a just culture, so everybody feels that they're empowered to learn from things that don't go as we anticipated, then I think the opportunity to do really big and significant change presents itself not as a difficult thing, but as a really achievable opportunity.
Hi, I'm Naomi Cowan from Platform Trust, and I'm thrilled that you've watched this talk because I think it's possibly going to change my practice. I think we often get caught up in new ways of working, and that's important, but today we heard about the importance of culture within an organisation and the importance of intent around your practice, and I really think that Joe has inspired us to really work on that. And not only that, but again to be reminded that we really need to work hard at listening, really listening to people who experience services, people who present to services and people who work in services, and listen with an open mind, and that with an open culture and a just-based culture will help, I think, change our practice. It'll be a natural consequence, but it'll be a change that will actually bring really good outcomes for people. And isn't that what we're all here to do?
Oh, kia ora, I'm Robin Shearer, Chief Executive for Te Pau o Te Whakaaranui, and we've just had the opportunity to hear from Joe Rafferty, Chief Executive for the Mersey Foundation Trust in the NHS. Some of the key messages around quality improvement and workforce development that I loved from Joe was be compassionate, have your workforce be supported to be compassionate, having co-production, doing whatever you do in a service, co-produce with consumers and families, such an important aspect of how you deliver quality care. Thinking about respect, bringing in values, and he was very clear, culture eats strategy for breakfast. So even as we embark on a quality improvement program across the mental health and addiction sector, we've got to think about those nuances that really are not just about changing practice and service, but actually how the culture engenders improvement and supporting our clinicians at the front line, our support workers, our peer workers to do the best they can, and acknowledge that we're a learning culture. If we want to improve quality of care, we've got to think about how we use some of the things that don't go well for the benefit of learning, and being open and honest and transparent about that. If you want to hear more about what Joe's got to say and his role as a leader and how he's taken the Mersey Care Trust from good to great in the Jim Collins way, then please have a look at the video, and we're going to keep in touch with him and hope to have him back next year. Ka kite.
I'm Clive Benson, and I'm the clinical lead for the Health Quality and Safety Commission Mental Health and Addictions Program. Just listened to Joe Rafferty, and I think he has presented us with some real challenges, one of which is to set very ambitious goals. Throw the ball out as far as we can and chase it as hard as we can. And another is the importance of culture over strategy. The culture trumps strategy every time, and a just environment and a just organisation also creates a learning organisation. Those are the key things that I've taken away from this morning. So a very inspiring talk.
My name is Grenville, and my role is the Service Development Manager at Mental Health and Addiction Services at Northland DHB, and I've just been to the Joe Rafferty presentation, and I found it really inspirational, really refreshing, what was really good about it was that he brings lots of different ideas around systems, operations and practices, and all geared around a trust culture, a move towards zero suicide, zero restraints. And the whole aim of that is how can you bring those learnings and place it and embed it within a New Zealand context. So really good for us in Northland because it's things we've been thinking about, some of which we've started, and this just sort of gets the ball rolling. So a really inspirational speaker.
So that was a really inspirational talk from Joe. It's really exciting to hear organisations that are being driven by compassion and the just culture ideas and a learning culture idea, and actually seeing some tremendous gains that they're making for the people that they're serving through co-design, through keeping their finger on the pulse, and through true accountability. Just an excellent presentation.
Hi, I'm Paul Henson. I'm one of the clinical leads at Te Pou Te Whakaaro Nui. I thought the presentation was excellent. I was particularly interested to hear how he used solution-focused language. So the idea of looking forward to what we'd like to have rather than looking to what we don't want to have. The ambitious target of zero suicide. Set the whole tone for presentation. But actually, if you think you can do the impossible, then you can start moving towards it.